Shane, would you like to introduce yourself?
Sure. So I'm Dr. Shane Morris. I'm a pediatric cardiologist and I practice at Texas Children's Hospital in Houston, Texas. I've been on faculty here about 16 years, and I run the program for cardiovascular genetics, and I have a focus on diseases, conditions, genetic conditions that affect the aorta and the arteries, like arterial tortuosity syndrome, Marfan syndrome, Loeys-Dietz syndrome, and vascular Ehlers-Danlos syndrome.
Dr. Nias, would you like to introduce yourself?
Hi, I'm Dr. Talha Niaz. I'm a pediatric cardiologist, and I also have a focus on connective tissue diseases, and I do cardiovascular genetics as well. And I run a program here at Mayo Clinic.
No, thank you. Dr. Fontenot, it's nice to have you join us, and we're excited that you're part of this today. Would you like to introduce yourself, sir?
Yeah, sure. Having a little technical difficulty here, but I'm on my phone, so it's working. I'm Eunice Fontenot. I'm one of the cardiologists at Arkansas Children's. And I made the diagnosis in Aiden, in Andrea's son, several years ago, and so been involved with his care for the last, how many years? 10, 15 years now?
We're looking at, 13 years now. So
yeah, 13 years.
Thank you very much. Armel, would you like to introduce yourself real quick?
Yeah, so I'm Armel Pindon. I'm the CSO of Cure VCP disease, which is in neuroscience, totally different, but I'm a co-project leader with Andrea on the CONECT project, which is Cardio-Ocular network for connective tissue disorders, and I'm a kind of scientific representation in the project.
Thank you. Maya, would you like to introduce yourself?
Hi, I'm Maya Brown Zimmerman. I'm a patient with Marfan syndrome, and I do a lot of patient advocacy work, and I'm also a genetic counseling grad student.
Thank you very much. And Jade, are you able to introduce yourself, or are you still on mute for a while?
I can quickly. I am Jade Day. I'm VP of A Twist of Fate. I am the parent of a son, 15, with FG1 syndrome, and I'm an X-linked carrier of it.
Thank you very much, Jade. And I'll introduce myself real quick. My name is Andrea Taylor. I am the founding president of A Twist of Fate for arterial tortuosity syndrome. I am a carrier, and I have a son that is 15 with ATS. All right, Armel, would you like to get us started?
Yeah, so I'm going to share my screen. I have several screens, so it's always a challenge. Okay, so that's just a brief introduction. I think everybody knows more or less the CONECT, and so the reason why we are here today is the name is a patient-led clinical meeting for cardiology. In the trying to identify the challenges in connective tissue for cardiology only. If I can go to the next one. So the goals of the project is to prepare all the conditions and gather all the conditions for establishing a new patient-centered comparative effectiveness research. So the aim is really to have all the tools so that we can run some research comparing different treatments or different methodology. So the first part of the project is based on education for a better description or understanding of the symptoms, education from the patient part and the education from the clinician part. And the other aspect of the project is really to identify the roadblocks and the technical challenges that are common in most of the connective tissue disorders. And today we would like to focus on the cardiovascular aspect of the CTD. So the agenda for today is in fact try to, I'm not a cardiologist, I'm a neuroscientist, so you will be the expert. And I would like to trigger the discussion about the challenges and opportunity that we could have in connective tissue in cardiology, and the few aspects I identified through literature was maybe a challenge for the arterial tortuosity common to different rare diseases in the standardization of measurements and the normalcy of criteria. Because if we want to establish a comparative study, but we don't have a standardization of the measures, then we have issue making any comparison. The other aspects, maybe, I don't know if you agree, would be the method of the aortic reconstruction, maybe might be diverse in might be different in connective tissue disorders compared to other disorders, and the imaging techniques. Do we need to focus more? Do we need to develop more research on the imaging techniques? So I don't know. I have a few slides on standardization of the methods. So the question would be: do we need development of high spatial resolution imaging and new generation of post-processing software when we talk about for arterial tortuosity measurements? What would be the best? Do you think there is a challenge in that? So I would just let you discuss these kind of things.
Sure, I can start off with that commentary. I think ours was the first paper really talking about arterial tortuosity in Marfan and Lowenstein syndrome a few years ago, and specifically in connective tissue disorders. And there are a variety of ways to measure arterial tortuosity. There's kind of an old way that was set up in the 1950s that was seen in elder adults, where you just look at a catheterization, like an angiogram, and you sort of say, are there full loops, are there S's, are there C's? It's a very qualitative measure. It's not very reproducible. That's sort of what was out there. There's something in the middle of the road that's quantitative and pretty easy to do, which we use, was an old type of measure. We just applied it to connective tissue disorders, called the arc over line or the distance factor, where you take a vessel that you're just describing the tortuosity. You measure the actual length in 3D space, which is very easy on imaging on CAT scan and MRI now. And then you measure the crow's flight distance, the straight distance, and you take that ratio. So I think that's a very easy measure. It's very easy to do on current imaging platforms, and I think that's the most commonly used. There are some advanced algorithms. There's an example of one at Stanford where they sort of do artificial intelligence, or they take the whole 3D volume rendered picture into account and do a very complex algorithm, which is probably a more sophisticated way to measure tortuosity. The problem is not everyone has those platforms, and they haven't correlated it with outcomes. So I think most cardiologists are moving towards the second, which is what we have done. We did it mainly with the vertebral arteries. The Dietz lab did it with the carotid arteries. We did find normals, but it was only based on 30 patients. For vertebral arteries, we'd love to have a bigger normal data set. And now there's several articles using it in the brain for cerebral arteries, measuring this arc over curve or distance factor. Some standardization should be out there. Like the way we do it is almost all these vessels are bilateral, except for the aorta. And so we take the maximum tortuosity of the two vessels, but should we designate right and left? And so things like that haven't completely been worked out. And if you do aortic tortuosity, where do you start? Some people have started at the aortic annulus, and people have started at the sinotubular junction. We start at the sinotubular junction because it's easier to identify on a CAT scan or MRI. Your question about new technologies, most of the current imaging platforms that do 3D rendering of the vessels, it's actually pretty easy now to measure. It's just extra time. A post-processing person has to take extra time in the analysis, and not every institution is willing to do that. But there's something called the center line technique, where you can plot dots through the vessel on the imaging software, and most processing platforms will now calculate the actual distance and the distance between the beginning and end point, and that can give you the same calculation that we do. I don't know if others, if Dr. Nayez or Dr. Fontenot wants to comment.
Yeah, we're doing similar to what Shane and her group are doing by measuring it, and we measure both sides. I'm not sure that we have differentiated right or left. Like you said, they're all paired except for the aorta. But it makes some sense if we're going to do that. There are so few patients out there that we should agree either to do it the longest or most prominent, or do both and identify them up front.
And Dr. Nias, what's your experience in measuring?
Exactly. I think I do exactly how Dr. Morris described kind of the second way to measure, and we go for the maximum tortuosity again in that sort of a way. So that I think is much more easier and accessible for most of the 3D processing softwares. So I think that kind of makes the most sense in terms of different places can kind of use that much more easily as compared to kind of the more comprehensive three-dimensional techniques. So I think that's the one that we use over here too for almost most of the conditions that we use the tortuosity index.
I will say the things that are lacking are a bank of normals throughout the system, because angiograms, 3D rendered angiograms of MRAs and CTAs aren't usually done in healthy people. So we've tried to do them in like accident victims, but a lot of them don't get angiography. They get non-contrast imaging. So if there was a bank of like normal angiograms somewhere out there that someone had done, I don't think we can do it under an IRB because there is some risk to getting angiography, but I think that is lacking. And then, perhaps a document really putting in one place, here's all the normals, here's the beginning point, here's the end point, and here's the reference values for a bunch of different vessels. We've defined that for vertebral artery tortuosity, but only in a young population. I don't think anyone else has defined it for the other vessels. Like we've usually said within a population, like within Loeys Dietz, like this is what the Dietz group did. They said, do the people with higher tortuosity have more adverse events than the people with lower tortuosity? So for that, you don't need normals. But I do get reviews back on manuscripts all the time that say, well, what's normal? And we just don't have that many people that have had normals. But we could, theoretically, you might be able to collect, like we could probably find 10 or 20, and if people could collect a bunch, that is a void.
So what would be the steps, in fact, to get all this normalization, and what action can we?
Yeah, the steps
we try to propose.
Define centers. We'd have to define a population that we think would have angiography, but likely would be healthy. Like sometimes cancer patients get these done, or sometimes trauma victims get them done, or suspected trauma. You might want suspected trauma, not actual trauma, so they don't have like a dissection from a traumatic dissection. So you'd first have to define a patient population. Then those images would need to be shared to a core lab. Perhaps we could do it in Clarity, perhaps we could do it with another core lab. Then an imaging post-processing, usually a technician or a physician would need to measure all those tortuosities done in a standardized way. And someone would, if it was a technician, a physician would need to oversee that. And then statistics would need to be done to, discover the distribution and minimum, maximum, and median for publication. But it would take quite a bit because you'd want, at least a couple hundred, I think, and you'd want to do lots of different vessels, the bilateral internal carotids, bilateral external carotids, vertebrals, aorta, iliac. Like you'd want to do a bunch of, and we'd want an age spectrum. In an ideal world. The other question is, tortuosity means something different in each of these diseases. So in Loeys Dietz and Marfan syndrome, it defines people that have high tortuosity are more likely to suffer an aortic dissection at a small dimension. But in ATS, as far as I know, we haven't had any dissections in ATS. And they have quite severe tortuosity. Same with Williams syndrome, they have quite severe tortuosity. And so in Williams syndrome, the presence of tortuosity actually suggests increased risk of stenosis and coronary artery ischemic events later in life. And so we also can look at what, it's been too hard in ATS because it's so rare, but what does higher tortuosity mean in each of these populations? It's a secondary question once you have some normal data.
And the other thing to add to that would be that I think every single group has looked at maybe different arterial bed, but I think combination of, if you have tortuosity of intracranial and vertebral, is that more concerning as compared to just having vertebral? And what's the reason why some people only have vertebral versus some have like the throughout the body, right? So a lot of those different, and again, the standardization, I think Dr. Morris has done a lot of work on the vertebral artery tortuosity. So we have, I think, a lot more standardization of the vertebral artery as compared to the intracranial. I think that needs to be kind of have more standardization, and as similar to the iliac arteries too, I think that also needs more standardization.
Another big group are the pulmonary arterial bed. My patient presented with the arterial tortuopathy mostly in the pulmonary arteries. And so those are the kids that have been operated, actually, are the kids that have pulmonary disease. So that's another vascular bed that needs to be studied, and how we define that, first, second, third generation, how far out you go, right, left, whatever lobe. I mean, you can see where defining a population of normal before we start describing abnormal and its implication on outcomes is going to be a job.
And that could be done from those same, if we got angiograms, we could get that to the pulmonary artery.
Which we have, yeah.
So if I can summarize this aspect, it's not that there is a need of new technology. It's more than that there is a need of normalization and standardization of what
right, and images, and we have the techniques to do that. It's just the hard work it takes to get those images, because they'll probably have to come from lots of hospitals. So to find those, and the platform to combine those on, and then someone to interpret those in a standardized fashion.
Mm-hmm. So do you think that should be a collaboration between Europe and US, or it should be only in US? Or
it could easily be done in Europe. And the way I would frame it, this isn't a biomarker for disease. So if you're looking at funding agencies, when you say tortuosity, I don't always understand what that means, but this is an imaging, it's not a serum biomarker, but it's an imaging biomarker for disease. So that's the framework in which most places understand what we're talking about.
So should that be done in collaboration with the FDA?
I don't think we'd need to use the FDA, because there's no medications involved. It's just imaging.
No, because there is a special section of biomarker in the FDA now.
I wouldn't know. I'm not familiar with, NIH does a fair bit of biomarker support, Department of Defense, other entities, because you're sort of always, rather than measuring disease, if you can measure biomarkers for disease that are better. So there tends to be interest in biomarkers. Most people, when they think about biomarkers, think of serum biomarkers, and so, but certainly there are other types of biomarkers.
Oh, imaging, imaging is really a big part of biomarkers now, and there is a special department for biomarkers qualification in the FDA. So that's the reason why I was just thinking.
That's an opportunity. That'd be fantastic.
Okay. Do you have any other ideas? How we just want to set, in fact, the priorities of research that should be done. Set everything so that we can go on with research. So standardization, normalization. Is there anything else you think?
And once you had standardization, normalization, then you can really, if we had a totally normal data set and got normal tortuosity and, shape of all these vessels, then you could go into all the diseases and look and see how that affects outcomes. And, part of Clarity, which is our, where we're a registry for multiple rare aortopathies, is we are collecting imaging from everybody, and we're trying to get all of their CAT scans and MRIs. So if we were able to collect this normal data, then someone could just pull our imaging bank of affected patients and compare them. And we have outcome data too. So, we hope to get 3,000 patients by the end of year 3. We're about 9 months in, and we have 1,300 patients.
Wow.
But we don't have all their images yet, because we just are finishing the negotiations with the imaging banks, but we do have their clinical data.
Oh, do you work in collaboration with RareX or Stripe or Citizen or this? No, you do everything by yourself.
Well, we have a funded program here at Texas Children's for Clarity right now, temporarily funded for 3 years. So if anyone wants more to provide more funding, but and so we have a group of people. We have a data scientist and a research coordinator, and then we have a steering committee made up of physicians all across the country that contribute, that kind of lead Clarity also.
Nice. Okay. So maybe we can move to the to the next. Where is it?
Sure. While Armel is getting the other slide up, Aidan and I went to NIH and started like the ATS group there, and I wonder if they don't have a group of normal scans that we could use.
It's possible they might. I hadn't, I worked with the NIH on a project with Turner syndrome tortuosity, and they pulled 200. They had a data set of 250 patients with Turner syndrome that had MR angiography done, and we reanalyzed all those patients. And they have a big imaging program there. They didn't bring it up at the time, but I'm not sure. We asked. I have 2 small data sets of normals, one from Italy and one from Boston Children's, but those are again only vertebral artery. But it's a good idea. We could ask them.
Yeah.
Because sometimes the nice thing about this is we don't have to go collect new imaging. If someone has angiography for any purpose, we can measure it.
So for ATS and carriers, there's not typically tortuosity, so to speak. Could you use them as normal? Well,
I wouldn't. I don't. I think it could be contaminating because if there might be. So when you look at tortuosity, when in our normal group, if we use regular VTI, we're using height-adjusted vertebral artery tortuosity now, but our first paper was on regular vertebral artery tortuosity, and in that case, less than 10% is normal, and over 10% is abnormal, because 95% of people are under 10%. But your eye can't really see tortuosity till it's 15 or 20%. So what we discovered, like in vascular EDS, people say they're not tortuous, but when we look at them, on average, their tortuosity is like 14%. So that means more than half have abnormally increased tortuosity, but it's so subtle, people don't notice. And so my worry about carriers is we don't really know if there's increased tortuosity or not because no one's ever studied it. And if we got an average of like 15, is that normal? Is that really reflecting the normal population, or is that a subtle increased tortuosity because you're carriers?
Well, that's a great point. Thank you.
No. So the next point, sorry, why can't I do? Okay, just clicking. Next point I noticed in the literature were really a debate on the way to do aortic reconstruction in connective tissue disorder patients. So would you agree that there is something to work on this, or at least to teach? Or is it something that's you think about something else maybe?
I think we'd have to have a surgeon on board. This is a super complicated question because the aorta is a really long vessel, and aortic reconstruction, you can reconstruct the aorta in multiple places. So, for example, in Marfan syndrome and Loeys-Dietz syndrome, an aortic root aneurysm is the most common, and we do an aortic root replacement is the main surgery we do there, and that is either valve sparing or valve replacing. You can also do an arch reconstruction, or you can do a descending aorta reconstruction. And then you can also, once you've had a dissection, you can either do open repair or you can do grafts, like an endovascular graft. And there's a little bit of a debate on that. So every part of the aorta, there's a different debate and different things that go into what you're going to do. So it becomes really complicated. I think there's not a ton of debate about the aortic root replacement right now, other than you want to get a valve sparing if your surgeon can do it. I think there's a lot of debate once you've had an aortic dissection about what to do. And I think ATS is so rare, and ATS can have aortic disease anywhere along the aorta, that's like an arch right now because there's just not enough data. I don't know if you guys, Dr. Fontenot and Dr. Nayaz, if you want to comment.
Yeah, I agree. I mean, I'm not sure. I'm not even sure the numbers that we accept for the Loeys-Dietz and for the Marfan group are even applicable to the disease category in the ATS group. We don't know what those numbers translate to risk. So, since we've never seen one of those kids dissect or know when they rupture, or if they do, we're still defining the natural history of this disease, basically.
Right. So the only patients with ATS that would get a reconstruction usually because they have a coarc because they're too small, but no one. It's really hard to know, like you said, what's the upper limit we should operate at since no one's dissected.
So would it be a question not only for ITS, but really the CONECT project is about all the connective tissue that we have. So it's Marfan, LDS, VDS, for all of them. Do you think that there is something that should be focused on outside of the aortic reconstruction, but anything that is a roadblock for doing new clinical research? Or
I mean, there's probably a lot. They're just so varied. It's really
pick two.
varied per.
We need 3.
We probably need to have like someone like Maral Owazian, who is the chair of cardiothoracic surgery in Toronto. You know, she could probably come up with the biggest question from their perspective, because there's just so many different clinical scenarios. It's hard to say this is the 1 or 2 most important surgical questions, because every disease is different, their risks and the surgery you would do. So like, is the right surgery to do a question, and when and in whom? Yes. But probably like one of the projects Clarity's doing is we're starting with Marfan syndrome, then Lewis-Dietz, but we're saying we're adding all these risk factors and saying who is going to dissect early, and you know, when should we operate? And we're only talking about aortic root replacement to prevent type A dissection in Marfan syndrome. Like, that's a very specific group. And our next question is to prevent type A aortic dissection, looking at the root and Lewis-Dietz. And that's going to take us 5 years just to answer those 2 questions. And so I think it's just such a big question, and every disease is different. It's hard. Dr. Nyes, I don't know what I didn't give you a chance to talk.
And I completely agree. I think we have slowly moved on from lumping all the connective tissues together to gene-specific measurements and going along with surgical interventions for those. And even then, in I think every specific disease, there's so much still to figure out. As you mentioned, all the risk factors for every individual disease, and in that same individual disease, different things. Whether they have tortuosity, whether they don't have tortuosity, does that change the element of when we do surgery for them? So there's still just in every single individual disease so much to still figure out. I think it would be hard to have specific 2 or 3 main questions. But again, I think I agree. It needs to be coming from a surgical perspective or from a surgein.
Yeah, as Dr. Fontenot said. Oh, sorry.
One of the things that we could do, since we're so early in ATS, as we're defining the natural history of the disease, is have some consensus on when these children ought to be studied. Should you study them every 2 years, every 3 years? And if you get an MR or a CT, do you do it from head to toe? Do you just the belly, just the chest, just the head every year or 2? And we should set a standard there, so what we expect as we're gathering this data, so we can start gathering it prospectively.
And we're actually writing, and I'm a little behind, we're writing the American Heart Association Pediatric Aortopathy Guidelines right now, and we've added ATS. Now, it's a consensus statement, so, we don't know what's right. I can't remember what we have for ATS right now. We definitely have head to pelvis imaging at diagnosis, unless if they're under 3 and not severe, I think it can be deferred to 3, since it would probably need sedation. I think that's what it says now at diagnosis. And then follow with echo unless there's specific segments on the baseline that are significant. And then, it's sort of like shared decision making after that for periodicity. I think it's like I have to look. I think it's 2 to 4 years or 2 to 5 years. It's very broad for ATS because we don't have that much, but we are trying to put some sort of structure in there.
Good.
So in fact,
does that make sense to you, Dr. Fontenot? I love your advice. We're having fun.
Yeah, like I said, I think we need to have some consensus, because we've learned with the Marfan, if you go this much in a year or this much over a certain time, then we need to follow you closely and consider surgical intervention earlier rather than later. The way we know that is because we gathered that data in a timely fashion to be able to make those decisions. And if we can think about that prospectively with the ATS group, and we can learn a little bit instead of having to go back and figure it out.
Yeah, and we'll be asking for annual echocardiography. It's just a cross-sectional imaging because it's so expensive and requires sedation. I think we
right. Yeah, I get it, but that data is important as we start out here.
Yeah.
Mm-hmm. The other thing I think in ATS specific would be the pulmonary artery reconstruction too, right? I think that's the thing that changes and kind of differentiates ATS so much from all the other congenital connective tissue conditions. So I think that's the other thing that may need some more data. I think we need to know when is the right time to do that and what's the right approach to do that. That also needs to be, I think, more standardized, I guess, or more studied. I think that would be the more better word here, to be studied more before we can kind of even standardize some of those.
Is there any history of ATS patients being operated on outside the chest for tortuosity?
I'm trying to think. We just looked at 12 patients and it's all thoracic.
They're all it's all the pulmonary arteries. Yeah, that's
But we
what
don't have any really older patients with it. So like, is it like some of the other ones where they can get iliac aneurysms later in life? I wouldn't be surprised, but does it matter since they don't dissect?
So yeah, we definitely need to concentrate a little bit on intrathoracic vessels for sure.
Yeah, I mean, maybe that could be a next goal, because that's a realistic goal, is understanding better the longitudinal natural history of all these diseases, especially the rare ones rarer than Marfan syndrome. There's very few longitudinal papers written. You know, Andrea, we're working on an ATS one right now, but it's 11 patients. We're looking at longitudinal growth of pulmonary arteries, aorta. That's it, pulmonary arteries in the aorta. But you know, we don't understand that for filament A, ATS, cutis laxa type B. They're also rare. There's no natural history papers. There's a few papers saying here's the genetics and here's their cross-sectional phenotype, but what happens over time, that's a big void in the literature. And maybe if you start with like, what surgeries are they having? What are the interventions? What are the things that are life-threatening? Then the next phase can be, let's look at surgical interventions.
So is ATS one of the only connective tissue disorders in the group for CONNECT or Clarity that have pulmonary artery stenosis?
I mean, autosomal cutis laxa type B can have it, but it's so rare. Like we have one patient with it, and we have a huge center. Now, I know there's a guy in India, I think I've told you about him. He has 40 patients because it's a founder there. In the Muslim population there, but that has pulmonary artery stenosis, and we haven't included the other small vessel. You know, ATS is big and small vessel diseases. A lot of the small vessel diseases have it, like Williams syndrome, Myhre syndrome. Myhre not too much, a little bit. Elastin arteriopathy. They all get pulmonary artery stenosis, alveoles, but those are different. Like they're connected tissue, but they're in a different bucket because they're small vessel diseases.
Thank you.
And are you guys including those small vessel diseases in CONNECT? My understanding was you were not.
It's Myhre, myelin, FG, Marfan, Loeys-Dietz, cutis laxa, vascular Ehlers-Danlos, and we had included Sticklers, but we've not had a lot of participation with them yet.
Yeah, we could do Myhre, but Myhre, the PA, we follow about 6 patients with Myhre, and none of them have PA stenosis. They do have some coarct and small aorta.
So the longitudinal longitudinal natural history study would be also for Myhre something necessary.
Well, I think so. Although the geneticist that runs the Myhre Foundation is super involved and super organized, and so if we did anything like that, it'd have to be in collaboration with them. I mean, she knows every case in the United States. Dr. Angela Lynn, she's a geneticist at a Mass General Hospital. I mean, I see a patient that she hasn't even seen her, and she texts me and says, "I heard you saw a patient." Like she is super aware, and she tracks. She probably will publish a longitudinal study. She's been tracking everyone's MRIs and has me send her measurements every month. It's just not been published. But Myhre is one of the ones that probably does have them cataloged somewhere. They're just not published. But there's not even a Loeys-Dietz longitudinal study. So there's no I mean, we did one, but it's not published, and I need to fill it out. Like we presented at HA a few years ago. But ATS,
for Myhre, there is one in Europe, with 12 patients but it's only 12 patients in Europe. There is nothing done in the US.
On Myhre?
Yeah.
Angela Lynn's published a ton of papers on Myhre.
No, on the longitudinal.
Oh, on longitudinal, yeah. I know she's collecting data because I've been sending it to her. I just don't think it's published yet, with Mark Lindsay, who's a cardiologist that she works with.
Okay.
But if we wanted to partner, I don't know if she's interested in partnering. She's kind of like, she's fantastic, but she's kind of like the mother of this group, if that makes sense. But if there was something we came to offer with her, then she probably would, but she's collected all the data.
Great to have one person. So the first thing is normalization and standardization in the first part. The second part is the longitudinal natural history study. And what about technology? Do you think that there is a challenge in technology that is very limited for the limiting factor for the research?
Well, I think a huge deficit that is totally overcomable, and we're trying to do this with clarity, but need way more funding. But if there was a way to partner, is that now, 50% of the hospitals in the country have the same electronic medical record system, Epic / MyChart. And now many of the records are cataloged in these EMRs, including CT, MRI, echo data, medication data, diagnostic data, surgical data. They're all in these gigantic databases, but we are not harnessing that data. And when we do registries, like our registry, people are hand entering data. They open a person's chart and they hand enter all the details by opening a chart and reading it. And that is a gigantic waste of time. And so, all the medication data could be pulled, the diagnostic data, they of course need to be double checked, the surgical data, and perhaps if we use those tools, people might code better. I mean, the coding's pretty bad. And so harnessing the electronic medical record system. So like one of the goals of Clarity, but we just have one data scientist working on this, is at least in our institution to develop algorithms like, number one, how do you find these patients, right? ATS isn't too hard now that you guys advocated for an ICD-10 code, which is great, but a lot of these conditions don't have an ICD-9 or ICD-10 code, or they're misused. Like in Marfan syndrome, it's used all the time inappropriately. So what's the most accurate way to find these patients? Like in our system, it's in the echo database, not in Epic. Number two, what's the best way to pull meds? And right now, if you pull meds, you get like a vomit of information that's really hard to digest. So could there be a script, like a program, you can partner with Epic and run it, and it gives you a really nice database of all your meds and your weight, dosing weight that you can use in registries like this? Is there a script you can write to pull all the surgeries out and have that coded to what that means? Because surgical codes don't totally align with what we think clinically. Can we partner with the Society for Thoracic Surgery, which has really good coding for cardiac surgery, and 95% use STS, and it's got excellent coding? Can we partner with STS or with our hospitals that join STS to pull that surgical data so someone doesn't have to hand enter it? So much more efficient use of the electronic medical record for building registries, and that saves everyone time and energy and can much more rapidly facilitate science.
And do you have, that's maybe a stupid question, but is there a way to pool medical data in US and Canada, for example, with the same system, or is it impossible?
Each system is different, but you could probably, so like we're starting with Epic, which is what 50% of the US hospitals use. They don't use it in Canada. I have a partner, Matt Solomon, who is an adult aortopathy expert at Kaiser Permanente in California. He's building a system in Kaiser Permanente, and so you can't use the Kaiser system in Epic. We can't use the Epic system in Canada. But if you have rules, if you say, this is how we did it, I think then once you go to a new system, a data engineer can look at those and say, well, this is how we would do this strategy in our system. Like, for example, finding Loeys Dietz patients in our system because there's not an ICD-10 code. We looked at pulling from Epic, which people can handwrite it in. We looked at pulling from MRI and CT, and we looked at pulling from echo, and we found that echo had the best and most accurate yield. So we already learned that. And then when you look at Epic, but then that didn't have the genes, so we have to go back at Epic for the genes. And so like if we took that to Canada and said, hey, you could run these 3 queries quickly and see what's most accurate. Like we already went through the labor of like figuring out what might work. And like, I think, yes, it would take a while to translate it to a new system, but you still save a lot of the work by just figuring out what the steps are.
So when you're searching in that EMR system, would there be a place where it would be like, has the patient had genetic testing, yes or no? And then if they did,
that doesn't exist right now. It would be great if it does. So genetic testing is a big mess. Genetic testing is, so you might look at labs, but a lot of people get outpatient labs, which aren't always in the EMR. A lot of times it's a scanned in PDF. So genetic testing, I mean, that would be great to advocate like at a national level for genetic testing, but it also causes life insurance issues. So people sometimes don't want it as easily accessible. So genetic testing is a really hard one. Although if we advocated to have it more routinely reported, one way we could do it is if we had a universal way, dot phrase of putting it in Epic records, like a universal key code. So there's something called natural language processing, which is where you search the whole record for like sentences that have certain patterns. And if there was some sort of key code, like genetic interpretation, formal genetic interpretation per CONECT, you know, and had like, it's always in the same format.
Yeah.
And if we push that to centers around the country, then at least cardiologists and geneticists, if they put it in their note, would be that way, and then that would be searchable. That's one possible way.
So as Armel and I are listening to you guys discuss everything, we're also looking at new research questions that we can present for this particular project and for others. So if you, who would it be that would need the most education about properly using the ICD-10 codes for these connective tissue disorders? Would it be the coding people in the hospital or the clinics, or
it's the hard part is it's the clinicians, but it's not the clinicians like us, like Dr. Fontenot and Dr. Nayaz are probably coding wonderfully. What I have found the error is, well, I mean, if you did a genetic dot phrase, it would be people like us running aortopathy programs or it would be geneticists and cardiologists mostly. But some things like using the right ICD-10 code, that's the people who don't take care of these patients that are miscoding usually. Like someone's tall and skinny and an ER doctor writes Marfan syndrome, or someone has twisty vessels and someone writes arterial tortuosity syndrome. Like it's not that educated. And to be honest, it's like, it's a really hard task. So instead, what you might want to do is take everyone who has an ATS code plus has like a genetics visit, or, you know, like there might be a combination of codes rather than trying to get the whole world of physicians better educated, because it might be endless.
Yeah.
Because people just, you know, it might be a combination of codes that are more accurate, or you only use codes coded by a cardiologist or a geneticist, you know, like you limit it when you do your search to people who've, you know, to people who would know how to use those codes. I'm sorry, I keep talking. Taha and yes, please talk.
The other thing that I think, which recently, as you may have heard a lot about the AI-based approaches and the natural kind of language processing approaches. We are doing some of that work here at Mayo. We're trying to build some of these different algorithms, which could be, I think, a very helpful thing in a lot of these, as you mentioned, finding the patients and then getting the data entered into a registry through an AI-based language processing type of software that can then be double-checked maybe for some number of patients. But so we have such a robust amount of data or information that we write in our charts. If somebody is able to just take that and put it in an Excel sheet, that would be, I think, the most helpful thing for, I think, all of us, and would accelerate the amount of work that comes out, the projects that happen tremendously. I think we're heading in that direction. I think a lot of the places are, but we may have to direct some of the efforts into this side of the world too, in the medicine research type side of the things.
And just like in what you're saying, Taha, I mean, even if we had a cut and paste script for all of our centers, we could test it. You could pilot it. You could say,
Exactly.
Let's try natural language processing or AI currently. And it might have like a 50-60% accuracy, but then we could all use the exact same format for our notes or for a section of our notes, like a coded part that's universal, and then extract knowing what that code looks like in 2 or 3 centers. And, you know, I hopefully would have something like a 99% auto yield from populating. I mean, that would be a totally feasible project and like so helpful.
Mm-hmm.
That would be easy to do with Epic. Just get you a dot phrase, send it out, have it in your store, and pull it up when you need it.
Mm-hmm.
I love it. That's like a 1,000% doable project.
So in the CEDAR, I don't know if you know CEDAR in the FDA. Sorry, I'm really into the FDA those days. The CEDAR department has a whole team about data and data managing and all aspects of data. Do you think we could try to involve those people in the question about how to collect the data in cardiology for the connective tissue patients?
I mean, maybe data. So we just hired a data scientist. So there are 10 different facets, a million different facets to data. So we hired a senior data scientist, but he has never worked in electronic medical record, but he did radiology AI for the last 7 years. right? And so he knows medicine, he knows radiology, he knows how to extract data from pictures, but has never worked with the EMR. So like, data's not data, like it's not all the same.
Yeah.
I almost think we could, if they want to help us for free, I think that'd be fantastic. I think you could almost come up with this among a community like ourselves, like Dr. Fontenot say, like if we just had developed, all work together to collaborate, developing a dot phrase, and then we'd need to have a data engineer or some natural language processor, a EMR AI person, a person who's used to doing this within Epic. Like I think we could do it with a smaller team, but if there's someone willing to contribute help, but it would need to be an electronic medical records data group, not just a data group in general, because there's so many ways. We looked at another woman who does breast cancer registries, and I thought her talents would work perfectly with ours, but she'd also never worked in the EMR. All her stuff got extracted from the EMR to a registry, and she'd never touched the electronic medical records. And she's done data science for 10 years. So it's just, medical data science modeling. And so it's just, there's so many facets of it.
Yeah.
Yeah, and these medical records weren't necessarily originally designed for patient care. Epic was actually on a foundation for billing, hospital billing, and we have adapted it for our clinical use. So you need somebody really facile with those kind of records and data to be able to extract the important things.
It all comes back to money.
Yes, but those people do exist. Like you could contract with someone who has these skills. There are lots of people that now have developed these skills. A lot of them work for Epic, or they work for organizations that extract data, or billing organizations. And so contracting was like, if you could, an inexpensive way to do it would be to get a group of people like us to develop a standardized template. We could enact that through something like Clarity, where we say, okay, centers, try this for the next 6 months, but then we'd have to have a data scientist or data engineer hired to say, what's the strategy now to pull that? And that would be the person that would need, payment or to employ. But I think one person could probably do it. And it wouldn't be a full-time person. It would probably be, a part-time.
And that might be something great for PCORI on some of their research grants that we could look at a little bit more.
Okay, I don't want to go over our time. Do you think about something else that would be really important to start doing good research in the cardiology field for connective tissue? Is there any other roadblock that you can think about?
I mean, I'm sorry, and I'll give everyone another opportunity. A huge area is mental health. I mean, that's not really a cardiology roadblock, but I think we cause a lot of the mental health problems in that people are afraid of what's going to happen with their heart. So they limit their activities, they limit their exercise, they have a fear of the heart because the heart is the thing that can cause them harm. And so I think we can be mediators of those mental health issues. We're also the people seeing these patients most often compared to geneticists. And so we could be the ones to employ some sort of screening or referrals or, I don't know the answer. I'm not a mental health expert, but the numbers with mental health, depression, and anxiety are enormous. And I think a lot of it's, teenagers and children on top of having a chronic disease, on top of not feeling like everybody else. It's a huge issue. I don't know how to answer it, but we're doing little pieces at trying, but that needs a ton of work.
No, something I have never thought about. It's true that the fear of exercising. Yeah,
it's huge, especially in adolescents and teenagers. It's a big deal.
Mm-hmm.
Well, one thing that we've learned through the CONNECT project is a lot of these patients have pain. And so that also, I feel, limits their activity. How, from a cardiologist standpoint, is there any way to help negate that part of it? If we were to work on the mental health and the pain to increase activity, do you have any suggestions?
Like Shane, I have to do a lot of work, and I get one of my anesthesia colleagues to educate me about all that, what the choices are, because since I was in school learning all that, the choices for treatment for those kids now is, this big. It's huge, and different categories of medicine I've never heard of before now. And so that would be a big, big bite for a cardiologist, I think, to become an expert or be comfortable prescribing those kinds of medications
Right.
to.
And it might just be routinely referring to the right group of people, right? And I think Dr. Fontenot is talking about, like, there's a lot of non-narcotic pain treatments now, like acupuncture, or biofeedback, or
that are very effective, yeah.
manifestation. And how you were going to say something?
I was adding to the same thing. I think exercise, other than just the mental health, I think element, the exercise and promoting that, and what is good for one group of the patients and what is good for the other group of the patients, and what's helpful, what's not, like an exercise prescription for some of these patients, that's another element of it that I think would be very helpful to even sometimes have like a sports medicine person who could be an expert in some of these conditions and can talk about it, that if you have this type of a phenotype and this kind of a orthopedic concerns, maybe this would be a good exercise script for you. So I think that if you give a script similar to your medications, I think that'd be helpful to promote some of that exercise element of that too. So
Yeah, and there could be group recommendations, because then a lot of cardiologists aren't trained in this. So if there was a reference document of what do I do about this. And Andrea, one thing about a lot of the kids having pain, I think some of the pain is caused because kids are so sedentary.
Yeah.
And so if they were more active, I think that could, not everyone obviously who has like major skeletal problems, but I think sometimes improving movement can help reduce the pain.
I totally agree.
Okay. Sorry, I think I have water coming in my office. But
Oh,
yeah,
that's
we
not
have, in New York, we are, it's diluvian. Crazy. Yeah, water is entering my office.
Go.
No, I can wait. Now it enters, so it's in. Anyway.
Well, I think we're close to the end anyway, and I really appreciate each of you getting on your Sunday afternoon and taking time for us. We did this today, and we're also going to do another one similar with ophthalmology in these rare conditions, but we're getting ready for the master class. It's going to be in January. So if you have any ideas or think of something later on after we get off the call, please don't hesitate to reach out to myself or Armel.
Okay. Thank you. Thank you, all of you.
thank you.
It was great to see all of you. Thank you so much.
Yeah.
And nice to see you guys.
Bye, guys.
Bye.
Bye. Thank you.
Bye.
Bye.